Yeah. Five, four, three, two, one. Yes, sir. Start. Dr. Ambedkar.
Friends, good
Okay.
morning to all of you. Today we are having the next session, which is devoted to vomiting, a diagnostic challenge. We have had two earlier sessions, one on fever and one on cough, and I'm sure you will enjoy this as well. And we have two panelists with us, both experienced, and I'm sure there will be a lot of good discussion. As usual, the format will remain the same, and I will get started with the basics first and then get on to discussing 8 different cases. And then I, along with my panelists, will discuss and make the points better and clear for all of us to kind of put it in practice. Can I have the next slide, please? The next slide, please. Yes, you know that we have Dr. Sagar Balarao and, of course, Dr. Nandesh, both well known in their field, experienced, and I'm sure we are looking for something good coming out of both of them for all of us to learn. The next slide, please. Now, just taking you through the basics, I think every time when the patient presents to us, we need to be very sure where is the anatomy of the disease. And I think when it comes to vomiting, it's not only just the GI or it's not just the upper GI or lower GI, but many other sites which also lead to vomiting, and therefore we must look at all those other sites. And there are multiples of them. Almost every organ can cause vomiting, and therefore you have raised ICT there. You have many other metabolic disorders coming out of liver disease, renal disease, of course, the IEM, and then even the autonomic nervous disruption, which suddenly starts with vomiting. And then, of course, you have adrenals too. Now, imagine when you have a child with vomiting, you need to discuss to begin with and analyze from which system it is likely to come. And don't take it always as a GI problem. And I think that is what I wanted to kind of impress on all of us. The next slide, please. Now, we know that the onset of disease is very important in an analysis, and I generally consider that if vomiting starts at the onset of the disease without any other symptoms, it's almost always GI. And then, of course, some of them may be self limiting, like a typical gastroenteritis, where vomiting stops by itself in another day, while in an intestinal obstruction or any other lower intestinal disorders, vomiting may continue. But vomiting at the onset as the first symptom, as against vomiting coming up later after some previous symptoms, possibly is not a GI as a rule. Well, in medicine, exceptions are always there. Therefore, keep this in mind. Onset of disease is very, very important. The next slide, please. The next slide, please. Now, we go usual to get to duration. And I think, again, here, I feel any vomiting that lasts for more than 48 hours, you must be aware we are missing something. It could be intestinal obstruction, yes, but it's not likely simply a common gastroenteritis. And I think the diagnosis of gastritis is really a throwaway diagnosis. And we should not be happy with just calling it as gastritis every time. And therefore, anything lasting for more than 2 days, we are concerned. The next, please. Go through all that. Next, please. Go through all that. Progress is important of each symptom. I think when there are multiple symptoms, we should have a progress for each symptom because some of the symptoms disappear while the others get worse. And that is very, very important. And then, of course, the pattern, whether it's an occasional, frequent, and recurrent. The next, please. And then, therefore, of course, the accompanying symptoms. I just wanted to rehearse this because we all know this, but few points that I made may be of importance And I'm sure our panelists will discuss all such issues when we discuss now the case scenarios. The next slide, please. Now, here we start with a discussion on cases, and the usual way we go by is we give the history first and the relevant findings, if any, and then give options to the delegates. And the delegates have to choose which option they feel is the right and the best. And thereafter, our panelists will discuss the pros and cons of right answers and wrong answers. I hope everybody is clear about it. So here is a child who is 2 month old, infant presented with vomiting off and on since last 1 month. Take a note, first 1 month he was all right. He's breastfed for the first month and then started with bottle feeding for whatever reasons. And the vomit starts almost each time the feed is given. But of course, the baby demands feeds again. I hope the history is clear and please look at every details. The next, please. Now, physical examination has NAD. I'm sure all of us know what is NAD. Really, nothing abnormal detected, but many times, friends, NAD stands for no actual examination at all. Or it's important. Okay, and therefore, not actually done is also an NAD. Many of us forget to do that. The next, please. Now, these are the options. Show the options. Can it be pyloric stenosis? Can it be GERD? Can it be a feeding error? Or could it be an achalasia cardia? Your time starts now. Well, majority of them have said feeding are errors, but there are some almost equal GRD and some of them even a pyloric stenosis. Okay. Now let me go back to the slide, please. No, none of them feels it's achalasia cardia. Okay, now let's have our panelists say that. We will alternate with each one of them talking first. Dr. Balerov, would you comment on what the delegates have said and how do you look at it?
Yes, the common is good morning, everyone. Good morning, sir. Uh, as the case says, a 2 month old child, and the symptoms is 1 month. The chances of feeding here is most likely because for was 1 month child was feeding very well.
Good. Now, what about our next panelist? Yes, please. What have
Sir,
you
you
to
are on
say?
mute.
Yeah,
Very
Sir,
good morning, Amdekar sir. Very good
yeah.
morning to esteemed delegates present here.
Good
Yes, sir,
morning.
uprightly said before presenting the case, we need to understand the scenario and each and every points enumerated here. What we see here, a 2 month old infant on and off vomiting for since last 1 month, breastfed for one first month, started bottle feeding. So here you have to see baby demands almost feed every time, feeds again. That means this itself rules out that appetite center is very fine and systemic illness. We are not dealing with any systemic illness or any intracranial pathology. Given the options, pyloric stenosis, gastroesophageal reflux disease, feeding error, and Achilles cardia, Sir has rightly told that Achilles cardia is not an option. Here, feeding error, we need to keep it in mind because aerophagia is most common when mixed with bottle feeding. The happy feeders, we tell it as where baby vomits and demands feed again. This is the commonest feature in gastroesophageal reflux also and early stages of pyloric stenosis also. But note that pyloric stenosis onset is after more than 3 weeks. 3 weeks to 8 weeks is the most commonest period. Here, baby has presented vomiting since before that period, commonest onset period. So most probably this is a esophageal reflux is happening coinciding with feeding error also mainly. So instead of reflex disease, we can take it as feeding error. Sir can elaborate further because reflex disease means we need to have associated symptoms also like growth faltering and respiratory symptoms also. Here we have only vomiting which limits the scenario only to the gastric system.
Thank
Over
you
to
very
you.
much, Dr. Nandish. And I think we are all very clear. Pyloric stenosis could occasionally start even very early in life, but to, as rightly said by him, a little later. And of course, it's a projectile vomiting. Uh, GRD, we have already discussed. Achalasia cardia, you don't get the feed in at all, and therefore it obstructs right there. But my question to both of you, do you see achalasia cardia in clinical practice?
No, sir. No, sir.
Yeah. Dr. Valera, what about
No,
it?
sir.
Yeah, so possibly it's a
No,
theoretical
not frequent.
possibility, but we are not very, very sure. But I'm sure as the time goes in adults, a continuous GR acid reflux might cause an obstruction to the esophagus, but not in pediatric practice. So, next slide, please. So, this was really a feeding error. And I think,
Respected
again,
sir,
yes.
Respected sir, it is started with bottle feeding. If mother has started with the cow milk, we need to keep it in mind that also, sir. Another possibility, sir. So whether it is functional or cow milk or only purely feeding error. In this scenario, it looks like more like a feeding error because first 1 month baby had vomiting without bottle feeding.
Absolutely. And I think bottle feeding is a culprit many times. Besides infection, etc., there are a lot of problems. Anyway, let's go to the next case. Next case, please. Now, this is another one. Again, a 2 month old infant presented with vomiting off and on since last 1 month. Again, the similar story. Exclusive breastfed and uh, surely vomiting 3 4 times in a day. And next, please. Physical examination showed weight was 3.8, the birth weight was 2.5 kilos, length was 55 centimeters. There was a mild icterus. Abdomen was distended in the epigastric region. Take a note of all this. I've given you the weight and length for you to analyze decision when did this problem start really. And with this clarity, again, last 1 month story, look at the weight length, gives you an idea when did the illness start really. And then there's a mild icterus too. Okay. But you have an epigastric fullness, not a right hypochondrial fullness. Okay. Show the options, please. Next, please. Now, could it be again pyloric stenosis, duodenal obstruction, GERD, or a neonatal hepatitis? Your time starts now. Well, majority have come out with neonatal hepatitis. Okay. And then, of course, equal division between pyloric stenosis and GRD, etc. Oh, we are almost getting on to 30% of each. Uh, it's very interesting, isn't it, that uh, we need the specialist to kind of opine on such final issues. Get back to the slide, please. Dr. Bolero, you can start now. This one, what do you think this is likely to be?
Yes, yes. First is a 2 month old child and has the vomit is a curd milk. Means the if there is obstruction, it has to be after the stomach. Means the pyloric stenosis or offshore during obstruction can be offshore. And second thing is there is a weight gain of 3.8 is a weight and birth weight was 2.5. Means the child is gaining weight. At the same time, there is icterus and abdomen distension. The thing is of hepatitis is mild jaundice might be coming to like might be deranged liver functions. The
You're
chances
mute.
of
You're mute.
neonatal hepatitis, yes.
Anything more, Dr. Balarao? You're mute. You're
Dr.
mute.
Nandesh can add.
Yeah. Can I come in, sir?
Yes, Dr. Nandish.
Sir, here we have 2-month-old infant vomiting on and off for last 1 month, exclusively breastfed. Please note that, and vomits curdled milk 3 to 4 times a day. That means here we have a scenario where milk is staying in the stomach for some time to get curdled. So there is no obstruction above the esophagus medium. It is below that pylorus level of pylorus. That is for sure. So because milk gets curdled and gets vomited. Here we don't know whether it is projectile vomiting or not. Maybe further history may aid us. The examination shows weight gain is very good and length is 55, growth is good, there is no growth faltering here, but mild icterus is there, abdomen is distended in the epigastric region. Seeing the growth parameters, we can infer that this is not a chronic systemic illness, and pyloric stenosis can also cause mild icterus because of prolonged continuous vomiting, starvation, then dehydration, and gluconeotransferase enzyme stimulation leads to mild icterus. This curdled milk 3 to 4 times on and off vomiting with growth, normal growth. It's in the early stages of the pyloric stenosis. My option would be pyloric stenosis here when I look into other options, sir. Anything you can please correct, sir.
Very good. Good. I think the point he made was that first he confirmed that it was the milk going down, curdled milk. Then the most amount. See, in the first case, I did not give you a curdled milk. I
Yes.
wanted somebody to ask me, what about milk, curdled milk or otherwise? Here, I have given you a curdled milk, but I have not given you by choice the color of the urine. Okay. This was indirect bilirubin due to the hepatointestinal circulation, and therefore it was a pyloric stenosis. The point to make was in a pyloric stenosis, occasionally because of starvation or enterohepatic circulation, the indirect bilirubin may rise a little and you may get jaundice. So this is not a neonatal hepatitis. It would have started much earlier, would have gone on worsening maybe, and therefore, see, this series is for pediatricians, and therefore I thought we will put something unusual but still worth remembering, and to that extent, this was a pyloric stenosis, and we have learned that just because there is an icterus, you don't run to the liver at all,
It would
and
be a transient unconjugated hyperbilirubinemia.
absolutely, absolutely. And take a note, the weight gain is only 1.6 really, so that's not 1.3, so that's not enough for a 2-month-old breastfed. He would have got certainly close to 2 kilos as well. Anyway, fine. So we just wanted the next, please. So this was a pyloric stenosis, right? Again, makes friends. Uh, I want to bring out something that I may have missed during my long career. It's not that I have always picked up, but many times you learn out of your own mistakes, and then those really are stored very well in your amygdala. So let's get to the next slide, please. Yeah. Now here is another 2 weeks old infant, a healthy infant. Okay, exclusive breastfeeding, presented with lethargy, refusal of feeds, and vomiting for last 2 days. So the first 10, 12 days, this baby was all right, healthy, breastfeeding well. And suddenly last 2 days, he has not been very normal. He refuses feeds, he's lethargic, and he's vomiting. And I think he's hospitalized. They gave IV fluids. CSF was normal. Routine tests were normal. So the next slide, please. Next, please. Now he was better over the next 2 days. Okay. And they observed him for a day. Baby was feeding very well. So they discharged. They did not know what happened, but they clapped their backs and said, "Oh, we cured this child." Because the baby was all right. And again, with same complaints, within next 4 days, the baby arrived again. Take a note, something unusual happening, suddenly happening, getting better also suddenly. We don't know why, and again reappearing. Your options are, show the options please. Could it be GRD, pyloric stenosis, hypoglycemia, or none of the above? Your time starts now. Well, this time nobody wants to talk about almost pyloric stenosis, yes, but some people feel it could be GRD. Now there are some who also feels that. Okay, but majority feel it's hypoglycemia. Okay, let's get started with that. Okay, uh, Dr. Balarao, please. Uh, what would be your probability in this child? Go back to the slide, please.
Looking at a 15 days old child with which had the CSF was done, it was normal. I like to information that they might have done a hyper sugar at that time, 15 days during first time when they visited hospital. Because if to be if the sugar was normal or lower side, that will give a clue. Hello.
All right. Uh, Nandish, your comments? Make it short. We have 4, 5 more cases. You're mute. You're mute.
Oh, sorry, sir. Sorry, sir. Lethargy, refusal of feeds, and vomiting, and baby needs to be hospitalized, improved, and returned back. This goes in favor of metabolic causes, sir. Here we have hypoglycemia. The reason of hypoglycemia we need to evaluate further whether it is sepsis or any inborn error of metabolism. This is my call here, sir. When compared to GRD pyloric stenosis, the scenario itself will not match.
Good. So I think both of you said that it's likely to be an inborn error of metabolism, whatever it is. Largely, a typical hypoglycemia could also be considered because many inborn errors of metabolism have a hypoglycemia as its own component. However, most of them would have also had a seizure because of hypoglycemia, and this child is just remaining lethargic and refusal of feeds. That might go a bit against a hypoglycemia, but yes, we have an inborn error of metabolism, and I think a small little difference between this IAM with hypoglycemia or without could be that it was likely not to be because seizure would have been the first symptom of a neonatal hypoglycemia. And the second is this baby has no risk factors to be hypoglycemic, really, like a preterm or sick baby or whatever. And therefore, you're right that this was an inborn error of metabolism. Next slide, please. So this was an IAM. What IAM, we won't be able to guess just by clinical finding, but it's good enough to know that it's some IAM and it needs a quick further investigation. I think what is peculiar about this is just 2 days of some IV fluids. Hypoglycemia would have got better only with the right proportion of sugar given, glucose given, not just the IV fluids. So small differences can make out that this was an IAM, possibly without hypoglycemia. And fine, I'm happy that both my colleagues have almost talked about the same thing. Let's get to the next slide, please. Now, this is an 8-month-old child. Now we are moving out from a very young infant to a little older infant. Now, this was also a healthy infant presented with vomiting off and on for last 2 months. Take a note, a long period. Anorexia, loss of 2 kilos in weight. On direct questioning, also constipation, urine plenty, and the child is irritable. Take a note of all this. Sometimes, after seeing the presenting symptoms, we need to ask some more details to the parents because thought process goes in our mind that we want to know something much more. And when we asked this, the mother said the baby is constipated. Take a note that this child is vomiting, still constipated, urine is plenty, child is irritable. Next, please. And physical examination NAD again. Your options are show the options diabetes mellitus, diabetes insipidus, metabolic disorder, or renal tubular disorder. Your time starts now. Good. I think all of them are talking about something unusual, something different. You can call it something metabolic. All the problems seem to be one of those which cause a lot of metabolic disturbance, and therefore, you are right. In effect, even diabetes mellitus, insipidus, renal tubular, are all partly metabolic disorders, but that's fine. I think let's get back to Nandish first. Uh, Tell us what do you think about it?
Thank you, sir. Sir, here baby was well.
Back to slide.
Yeah.
Yeah, go ahead.
Here baby was well for last 2 months, presented with anorexia, loss of 2 kg weight, very, very significant, and baby had constipation and polyuria, urine was plenty and irritable. That means more than one system is involved here. Renal system is also involved and CNS system is also involved here. So when we look at the options, sir, these kind of symptoms are most common in renal tubular disorders where constipation can occur due to electrolyte loss, sodium potassium loss, and polyuria is a feature of RTA also. So that becomes the first the illness that we have to keep in mind. Metabolic disorder could also be, sir, but diabetes mellitus and insipid, this sequence of symptoms will not match with these options, sir.
Good. Dr. Valero, please.
You're
You're
muted.
Looking at the history, for first 6 months, child was fine, but in last 2 months, child has anorexia and weight loss. That's significantly implies that there is something which is happening, which means findings by loss. And looking at the diabetes insipidus and mellitus, the chances are very less. Of renal tubular acidosis, if you see there is a plenty urine. If you plenty urine and irritability means there is some metabolic things happening. The chances of renal tubular acidosis of
good. So I think the point I wanted to make in this child is two things. He's vomiting off and on, and even then he's passing a lot of urine. Now, does it mean it's a polyuria? Yes, it does. Because in an infant, a polyuria is not easy to make out, but somebody who is vomiting off and on for last 2 months, it's and also anorexia. Okay, he's not feeding well and still vomiting. And where is he passing urine? Plenty. So that puts us to polyuria, and polyuria could be diabetes mellitus insipidus or renal tubular, and therefore rightly our start would be that. Now Look at further. Constipation would be common to again many, but what is typical in this child is he is irritable. Now, most of the other conditions like diabetes mellitus, for example, or renal tubular would be more lethargic, whereas this child is more irritable. What does that mean? In a diabetes insipidus, because there is a hypernatremia, the brain cells are getting dehydrated, and therefore irritability is a prominent symptom of a hypernatremic child. And therefore, again, between all this, see, I have chosen the cases that I have seen, of course, not that I have diagnosed rightly to begin with. Again and again, I say the same, that whatever I have learned retrospectively, I want to kind of spread so that next time one doesn't forget about all these details. And therefore, this was an irritable child. When did we get electrolytes? Hypernatremia. Well, I said hypernatremia in a dehydrated child with plenty of urine. Now, that looks something weird, and this turned out to be a diabetes insipidus. Again, friends, for pediatricians, we don't want to just do one gastroenteritis or some intestinal obstruction. We know all that. The whole idea of this is to stimulate our gray cells, and you must be wondering, at the age of 84, mine, what gray cells are remaining, God knows. That's why I am getting all the feedback from Nandish and Dr. Balarao, so that whatever little gray cells are remaining are still getting stimulated. The next slide, please. And therefore, this turned out to be a diabetes insipidus. Again, unusual cases, but now we are pediatricians going one step ahead of a routine medical practice. And I think that keeps our interest in practice a great deal, because most of our patients are easy for us to go by, but occasional one, everyday one, will make us learn a lot. The next slide, please. Now, this was another older infant, healthy infant, presented with stridor and vomiting for last 1 month. Now, here's another symptom besides vomiting, and here's also stridor. The next, please. And then physical examination showed that he has an expiratory stridor. Take a note of this. Normally, it's always an inspiratory stridor. This was an expiratory stridor, and there were no other abnormality on physical examination. Your options are, show the options. The options are laryngomalacia, subglottic stenosis, tracheal compression, or a bronchial compression. Your time starts now. Again, a divided opinion. Yes. Let's start with Nandish again this time. Get back to the slide, please. Nandish, your analysis. You are mute. You
So
are
you are on
mute.
mute.
Thank you, sir. Here we have 8-month baby with stridor and vomiting for last 1 month. Importantly, we need to understand here it's expiratory stridor. What we see in our common clinical practice is inspiratory stridor, where laryngomalacia is the most common cause. It causes vomiting due to reflex actions, vagal stimulants, and the reflex action. Here, options both laryngomalacia and subglottic stenosis both cause inspiratory stridor, and tracheal compression causes the expiratory stridor, and no other anomalies is there, and bronchial compression will not present like this. So this is my call, sir.
Oh, Dr. Balarao, please.
Yes,
You are mute. You
basically,
are
when there
mute.
is stridor and vomiting, it implies that the child the pathology is more of respiratory vomiting, and that is since to last 1 month. And second, rightly said that most of the time it is a inspected stridor. Man, and if that is, then the chances are of upper GI, upper respiratory conditions where there is a inspiratory stridor. In the expiratory stridor, the causes are below the lower, the lower below the epigastric region, and the chances of tracheal compression gives an basically expiratory stridor. So my diagnosis will be more of tracheal compression.
Very good. So I think it was clear that you had an intrathoracic obstruction, okay, lower down, and rightly said that's an expiratory obstruction, and therefore something compressing lower down intrathoracic. Now, what could that be? Any thoughts on that,
It could be a
Nandish?
vascular compression ring, sir. That is most
Foreign body, it can be foreign body or a vascular ring.
one more.
Fine, excellent. See, the point that he made was this was for a short time. Had it been a tumor somewhere compressing over time, then it would have given some other symptoms first and then on to it. This is in a short time. Show the slide, please. Next one, it did turn out to be a vascular ring. Very good. See how good experts can clinically get a final diagnosis. Okay, and excellent. The point that we are learning out of each case is something different, but something very much to remember once in a while. And I think that's why this was typically a vascular ring. Both my colleagues brought out very important points. The next case, please. Now, this is another older child now. We are moving from a young infant to now an older child. And now, this again is a healthy child presented with irritability and vomiting off and on for a month, and followed by a sudden crying episode and generalized seizure, was hospitalized. Again, take a note. He was irritable and vomiting off and on for a month, following which one day he suddenly cried a lot and ended up with a generalized seizure for which he was hospitalized. The next, please. Physical examination showed he was drowsy, but there was no localization. But he was drowsy when examined. So take a note that you are examining a drowsy child, uh, apparently no localization, and your options are now one, could it be a metabolic disorder? Could it be chronic meningitis? Could it be a brain tumor? Or it's none of the above, something totally weird and different? Your time starts now. Well, back to the slide. I'm happy that everybody feels one of the three must be there, and none of the above is not a right answer. Okay, so that part looks good. Okay, now let's get to Dr. Balarao first this time. Dr. Balarao, what would be your way of analyzing this?
So the 3-year-old child presenting with an irritability and vomiting, it implies when with she's crying, and it might be just an aura, and with sudden of cry and general seizure means the cause is CNS cause. And second is I'm only doubtful about the history of fever, because if there is history of fever, it directly gives a like a might be meningitis. And second is if there is no fever, so the chances of I'm confused with the brain tumor also. And for metabolic disorder, the history has to be long, and for first 3 years, child was healthy. So it might be an chronic meningitis, or might be an chronic meningitis might present with the mild fever, and mother might have missed it.
Good. Nandish, your
Sir,
Thank you.
comments.
here 3-year-old child has irritability and vomiting on and off for a month, followed by sudden crying. See, this symptom is a very characteristic symptom, and generalized seizure and hospitalized. Where we this all these symptoms most commonly match with raised intracranial tension, probably brain tumor. This sudden crying would be due to stretching of meninges. These symptoms can also cause in the metabolic inborn error of metabolism, but this sudden crying and followed by general seizure goes well with raised intracranial tension brain tumors.
Fine. Now look at the closely the whole story. For a month there is irritability and vomiting off and on. So the story starts with irritability and vomiting off and on, almost meaning that there is a likelihood of a raised ICT. Okay, that's number one. Because he's irritable. And that's equivalent of headache, for example, in an older child, and then vomiting. So if you take care of irritability and vomiting for a month, then you are talking about a raised ICT, and then you are looking at whether it's going to be a neurological disorder. But the question is, are we dealing with chronic meningitis or a brain tumor? Now that's what we want to discuss here further, having said that it's a neurological problem. Now, take a note that this neurological problem, which is not localized as yet, suddenly after a month decides to come out with sudden crying and a generalized seizure. The point I wanted to make on this slide is that sudden crying is a focal symptom and then followed by generalized seizure. So it's a seizure which started focal but became unaware of the sensorium. So focal with impaired sensation. Okay. And that's why generalized seizure. What have we learned to analyze in generalized seizure? To know whether it started focal and became generalized or whether it really started as generalized. And any symptom which is prominent before the onset of a seizure needs to be taken as a possibly a focal seizure, and therefore now construct the whole story. You have a raised ICT which suddenly throws up a focal seizure for which he is hospitalized, and therefore this turned out to be a brain tumor. Again, what I learned always with having made mistakes as well, again and again, I repeat the same thing, that everywhere there is a clue that our gray matter does not take it well. And why is that? Because we see but we don't observe, because we hear but not listen, and because we know but we don't think. So that's the problem with all of us mostly. Okay, and therefore, next please. So
And
this turned
another
out to
one
be a
point, sir.
brain tumor.
Sir
Yeah,
Amdekar, sir,
yeah,
a 3-year-old child presenting with irritability on and off is also a correlating factor, sir.
yeah,
Irritability followed by vomiting.
yeah.
Sir.
See, most of the metabolic disorders are sudden in origin. Okay. Uh, this has gone on for a month also. So I think these are small. See, I every time I've seen some different unusual case, I record it in my uh, diary, and then I look at what I've learned out of all this. And that's why this situation, it turned out to be a brain tumor. Can we have a next slide, please? Next case. Now, this was again an older child, okay, normal child, presented with vomiting off and on for the last 4 months. Vomits ingested food, there are no other symptoms. Okay. Only vomiting, but for last 4 months without any symptoms. Next, please. Physical examination NAD. Show the options, please. So your options are functional vomiting, chronic dyspepsia, chronic upper G obstruction, or none of the above. Your time starts now. Again, I'm happy that nobody wants to say none of the above. It has to be one of the three. Sometimes it could be none of the above also. Okay, but let's see that. So back to the slide, please. Dr. Balarao, your turn now again. Uh, what would be your views?
Yes, yes. Is a 4-year-old child presenting with vomiting, which is ingested food, means it has not gone to the pylorus, or it might means most often it indicates it's an upper GI, and if it is upper GI in that presented vomiting and on off for last 4 months, means it goes in favor of it's long standing. So the chances of like a chronic upper GI obstruction, or my chances are more. And second is for functional vomiting. For functional vomiting, it has to be like a continuous, and might be the content might be digested food, or it might be processed like a curd milk or something. And for chronic dyspepsia, the child might vomit immediately after the feed. So the thing goes in more favor of chronic upper GI obstruction.
Nandish, your comments?
Thank you.
Sir, here we have a preschool child, 4-year-old child. For last 4 months, he has vomit on and off, and he vomits ingested food and no other symptoms. When we look at the child, this scenario is most common in functional disorders, which we call as rumination or voluntary uh, induction of vomiting, commonly observed in preschool children, sir. In upper G obstruction, we do not see like this vomit ingested food immediately after taking feeds, and also other symptoms will also be there, whether growth faltering will be there, and fluid disturbances, dehydration will be there, symptoms will be there, sir. Physical examination will definitely give answer to chronic G obstruction, whereas in functional vomiting, physical examination will be normal.
Fine. So again, the points made are that in spite of 4 months of problem, this child seems to be not sick. Okay. Take a note of that. Whereas some obstruction would have gone on even worsening, there could have been a metabolic disturbances coming up, and then he would have been more and more sick. That has not happened. And that's the reason why this is most likely a functional vomiting. But a point I want to ask both of you is dyspepsia, which is so commonly diagnosed in older people, do we see this as a problem in pediatric at all, or we should forget dyspepsia? What do you think, Nandish?
No, chronic dyspepsia, as far as me concerned, very uncommon, sir, in my clinical practice.
Dr. Balarao, you agree with this?
It's uncommon, sir. Uncommon, sir. Uncommon, sir. Yes, sir. Uncommon.
Yeah, so, yeah, Dr. Balarao, you want to say something?
No,
No,
sir.
we can't hear you.
It's a very uncommon chronic dyspepsia.
Yeah. So I think we have learned two things. Don't call anything gastritis. Okay, it's like not knowing what it is. In other words, and same thing about dyspepsia, etc. I'm sure all these problems may come up, and we have been taught even in undergraduate days that it's hurry, worry, and curry. Okay, and fortunately, our children are so innocent and happy in life. They do not know what's happening in the world at all, and that's the wonderful time to be happy. So possibly we don't encourage anybody to call dyspepsia or gastritis, and this turned out to be next, please. This turned out to be functional vomiting. No, so take a note of this. Okay. Now this is just to show you again that many times an adrenoleukodystrophy presents as an adrenal disease and not leukodystrophy. But an MRI at that time could have shown definitely white matter disorder. The point, how I diagnosed it, I missed this. I was ready to call it a functional vomiting. But when I did the electrolytes, I suddenly saw a low sodium and high potassium. Now, seeing low sodium and high potassium, I said, no, 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 it's an adrenal disease. Now, when I was a resident 60 years ago, Adrenal disease was thought to be due to tuberculosis. Okay, that's the only Addison disease we knew. And thereafter, TB causing adrenal became rare and rare, or we don't know whether we diagnosed TB much before adrenals got involved. But hardly we saw that kind of Addison's disease. And then I suddenly realized that today the chronic adrenal disorder in pediatrics could be an adrenoleukodystrophy. And then I went to the literature and found that many times vomiting is the only first symptom for several months before the white matter disease comes in. And at that stage, if you did an MRI, you could even diagnose it as a white matter disorder. Again, an interesting thing to learn. And I'm sure I'll ask both of you again, do we ever see a chronic adrenal disorder? Addison's disease. Oh, all that we read in undergraduate days.
No, sir.
For us,
Very,
Addison's
very
disease.
interesting case to first, we must admit, very interesting case.
So I think we learned that chronic adrenal disease, most of
It's a very
them are
tricky
acute
case.
adrenal, like a neonatal one, suddenly sepsis, adrenal failure. But chronic adrenal diseases are not common in pediatric practice. Keep in mind this. This turned out to be a leukodystrophy. Anyway, the last slide, please. The last
Sir, can
case.
we answer like a none of? Can we say that none of the above?
Yeah, that's right. That's right. Okay, but how I missed this? I called it functional. Okay, and then they came back and said, now we have another neurological problem. I said, my God, this is an adrenoleukodystrophy. Okay. Anyway, everything to learn after making mistakes. This is the last case, and then I'll wind up with some one or two slides. Again, an 8-year-old child presented with acute episode of severe vomiting that lasted for just 2 days. Okay. At the end of 2 days, he vomited several times and what to be hospitalized. But at the end of 48 hours, something happened. He stopped vomiting. The next page, and again, all that you saw was he required IV fluids. He was hospitalized, and mere IV fluids only settled him. Nothing else was given. He was NBM because he was vomiting continuously. And at the end of 48 hours, he stopped vomiting. He was as happy as before. Show the options, please. Your options are now look at sorry past history. There were similar episodes off and on, and he would get hospitalized, take IV fluids, and go home happily. Okay, options are one recurrent intestinal obstruction, functional disorder, recurrent dyspepsia, and none of the above. Your time starts now. Okay. Friends, please take a note. I just said about 5 minutes ago that dyspepsia is not a pediatric problem. Okay, it's an adult problem mostly, right? You're right that dyspepsia does occur, I imagine, but none of our experts have seen it. I also don't call anybody dyspeptic, but there could be better etiological diagnosis. Get back to the slide. Nandish, your comments first.
Sir, 8-year-old child presented with severe vomiting lasting for only 2 days. So required only IV fluids, no antibiotic is given. So there is no infection here. And past history of similar episodes over 2 years is on and off is there. So these symptoms goes in favor of cyclic vomiting syndrome, sir. I am for that. So this none of the above is the answer here, sir. Cyclic
Fine. Dr.
vomiting.
Balarao, your comments.
Yes, sir. Basically, when settled with just IV fluid, and second is there is no history of like an examination. It is NAD, means abdominal distension or vomit, lose motion. So the chances of like a recurrent intestinal obstruction goes down. Second is recurrent dyspepsia is not common. So it might be like a functional disorder, or we might have to get investigation and again think of.
Fine. Next, please.
hormonal disorder.
So this was a cyclical vomiting. I think this is not uncommon. This is almost like a migraine equivalent, and therefore we keep in mind sometimes the recurrent abdominal pain could be migraine and so on. The next, please. And therefore, this did turn out to be a cyclical vomiting. Again, it seems to settle down over after some episodes by themselves, and we all know that. The next slide, please. Now, I just summarize that. Next, please go on showing everything. Now, vomiting often a challenge to diagnose and management, and we have seen 8 different types of vomiting challenging all of us. The vomiting later in the course of the disease is always something serious. Please make a note of that. Persistent or recurrent vomiting needs a proper evaluation. Causes vary from physiological to pathological to functional. Imagine that we had a feeding error, we have a functional disorder, and we have many pathological disorders. And I think what is important is most of the time we do make out that is something is different. And I wanted my experts to talk about this food intolerance or food allergy. Okay, today cow's milk protein allergy has taken a big toll. Okay, I don't know whether wrong with cows or wrong with us. Okay, uh, so let me ask both of you one after another. First, uh, then this cow's milk protein allergy. When do you diagnose that?
Yes, it is very common in our clinical practice, sir. Two kinds of presentation in there. One is IgE mediated, one is non-IgE mediated. When IgE mediated, with this vomiting, the irritability is most common. In non-IgE, colicky stomach pain is common, along with the dermatological manifestation, dryness, and growth disorders, faltering will also be there, sir. It's quite common, sir.
Fine. Only thing is that there is no test to confirm this.
Yes,
So
sir.
it's
Yes,
a
sir.
clinical diagnosis, and whenever there is a clinical diagnosis, one has to be very, very particular whether it follows a typical characteristics. Sometimes it could be abdominal pain, sometimes it could be some blood streak in the stool,
Yes.
and many, many other etiologies can almost simulate them. Therefore, besides, of course, I'm not trying to say don't blame the holy cow, but and now the gastroenterologists make me afraid to say that. But sir, the baby is on breastfeeding. They say no, mother's cow's milk intake is also causing the baby.
Yes.
They make me afraid of everybody likely to have cow's milk. But I understand that there are definite criteria to diagnose, and most of them wear out after some time by themselves. Yes, and Dr. Balarav, your comment on food allergy in general. Okay, people are very happy to say, "Oh, this food doesn't kind of I can't tolerate it." What's your comment on food allergy?
No, basically, this is right now. There's a lot of fast foods and these things. So the things people have very subjective opinion. But what I can advise in a clinical practice that okay, if you think there's allergy, stop, don't take. And basically, there are the limitations of testing the and getting confirmed the exact allergy. And there are some centers where this can be done, but practically, if it is allergy, if they have experience and they have to be vigilant, they can restrict that food.
Fine. So again, we know that allergic manifestation may come within a short time, within a long time. Okay. And it's again not an easy proposition to diagnose clinically. And I think at the end of all this, today, friends, we have learned how difficult cases can also be reasonably analyzed to a near extent possible. And of course, uh, investigations in that order would have always picked up all that we talked of. I think
Sir, I
having
have
done
one
that,
doubt, sir.
we
I
have
have
to
one
go with. Yes, any comments, Nandish, and
sir.
any comments,
Sir,
Balera?
in my practice, cow's milk, when mother is taking cow's milk, sir, what I have seen, rather than vomiting, constipation and dry skin is more common when mother is taking cow's milk, sir.
Very good. At least, is it only cow's milk or buffalo's milk and ass's milk also?
the cow's milk most common. Along with that, this maida products, na sir, they
Okay.
also cause this allergy manifestation, GI manifestation more commonly, sir. Junk foods and the maida
Dr.
products.
Balarav, your comment last, anything specific?
No, I will just summarize as you have summarized, sir. Like vomiting is not only restricted to GI problems. If there is vomiting with some, you have to think for other than GI causes for the causes of vomiting.
Good. I think with this we end up. I hand it over to Dr. Amarjit. But before that, let me make a confession. When I started, before we started this, I could see my image. And I hope, Dr. Amarjit, you also saw my image once. And I don't know where I clicked wrongly. Uh, Surely it's an 84-year-old senile brain doing something nonsense. And I was worried whether I could go about discussing complicated cases well. But I had two excellent people with me. So I was sure that they will always take care of my senility and therefore excuse me for not being shown. How can I show my face when I'm already senile? So back to Dr. Amarjit.
We missed your face, sir.
No, no, absolutely not, sir. That was a very inspiring and excellent session. So I think we have a few questions from the audience's end. With your permission, can we do that? Sir, the first question is how do we clinically distinguish functional vomiting from an organic cause? Like, what are the key pointers that we should be looking for?
Nandish, would you take that question? The question is how do you diagnose functional vomiting? Okay, you're mute. You're mute. Doesn't matter. Dr. Balara, would you take that question? How do you diagnose functional vomiting?
I think, Dr. Bhalara, you're on mute.
Yeah, mute.
Could you please unmute yourself?
Anyway, I feel that functional vomiting is a symptom, any functional disorder is a symptom of convenience. It comes at a convenient time. When a child wants to go out and play, there is no problem. Be
Hmm.
it headache, be it abdominal pain, be it vomiting. When the child is enjoying something, there is never a symptom. But when a mother asks the child to start studying or behave properly, a symptom comes up. That is number one. And another issue is that it does not upset the health mostly. And that's
Hmm.
why a diagnosis of functional abdomen is real, functional vomiting is really exclusion of every cause. But
Yes.
even clinically, in the first few days, you can almost make out that this is unlikely to be pathological, but be careful, it could fool us completely. Amarjit, back to you.
Yes, yes. Thank you, sir. The second question is, are there situations where you feel the long-term use of antiemetics is justified, or should their role always remain short-term?
Yeah, again,
Understood.
Nandish, are you on that? Yes?
No,
Yeah.
long-term use, no anti-emetic drugs can control to the 100%. It should be of limited use to control the symptom. Long-term medication is not at all advised.
Okay.
Good.
We need to understand the cause for vomiting, as sir told. It is not treat the symptom. We need to treat the cause. What is that reason?
Okay.
Very good. The only question sometimes is when somebody is on a cancer therapy, vomiting often is a kind of a continuous problem, and you may have to tide over by that. But the point has made clear that we don't use antiemetics more than a day or so to begin with, if at all. Otherwise, antiemetics don't stop vomiting. Vomiting stops by itself You give a credit to antiemetic maybe, or a never stops because you have not diagnosed it. Yes, Amarjit, back to you again.
Yes, yes.
Is there any
Thank
more question?
Yes. So another question is, could you share a few examples where vomiting is usually self-limiting and tends to resolve on its own without any kind of medications or management?
Nandish,
Any food allergy will cause, sir. Any you take some food, it causes vomiting.
Mm-hmm.
So when you remove that food, the vomiting stops. Like that, other causes, stress, cry, cough, the extraintestinal causes all stops when the extraintestinal problem is reduced. So
very good. So, vomiting stops by itself when the irritant passes through stomach down or out. And therefore, as rightly said, cyclical vomiting is one of those which take time to stop but stops anyways by itself. I think if there are no more questions, our time is almost up. Thank
We
you
have a
very much,
last. Okay.
colleagues. Okay, back to Amarjit.
Yes, last
Thank
question
you.
for today, sir. Many pediatricians face parental pressure to treat immediately. So, how do you balance reassurance with clinical caution when the diagnosis isn't yet clear?
Nandish.
it is subjective, sir. Subjective. It all comes through clinical practice. When Amdekar sir says the case, it is totally different. When I say it's totally different. We will all learn by experience of communicating with parents and taking ahead. How this scenario should be looked into it.
I think whenever there is a problem like this, uh, for me it is easy because many times I see a patient for second opinion, and then I wonder, uh, when you go out to the market, there are shops which sell seconds product, which means the product which is defective somewhere. I wonder whether patient comes to me for a second opinion means a defective opinion. Okay. But for me, it becomes easy because the common things are always ruled out, and several tests have been also done. So my job is to find out how the rare problem exists, which the investigation done do not show. So I start the reverse way, and then it is. But friends, when we are not sure, like a functional diagnosis, for example, always add on to the parent to say that I feel there is nothing pathological, but try to understand what I'm trying to say. Take away the stress on the child. Try to encourage him to do what he likes to do and make him happy. And let's see over time whether my diagnosis is right, but keep your eyes and ears open, and I will also keep my eyes and open. Okay, so that don't commit, but counsel them. Don't write medicines, but please counsel them. At the end, for me, again, it's easy. When somebody comes to me for second opinion, at the end, I tell them, look, with whatever experience I have, I still can make a mistake. So keep your eyes open. And you know what I get in return? Sir, don't be so humble. How can you make a mistake? What a thing. Being humble is a good idea. Counsel a patient well, right? Amarjit, back to you
Yes,
again.
thank you, sir. And I think as we come to the close of this insightful session, I extend my heartfelt gratitude to you and for this invaluable perspectives and for simplifying such a complex yet common pediatric concern. A very warm thanks to our panelists, Dr. Sagar Bhalerao sir and Dr. B. Nandish sir, for their thoughtful contributions and for sharing their practical viewpoints that enriched today's learning and discussion. So, and of course, thank you to all our attendees and listeners for your time and engagement. Let us carry these learnings forward to enhance our diagnostic thinking and clinical care for every child that we treat. Regarding the next topic of discussion and the next webinar and when it will be held, we'll be surely updating you regarding that. So, till then, stay curious, stay clinical, and above all, stay compassionate. This is Dr. Amit Pal signing off. Thank you, everyone.
Thank you. Thank you. Good day to all of you. And thank
Thank you.
you, Dr. Nandish and Dr. Sagar Balarao,
Thank
for being on us with her. And I enjoyed both of you commenting. Thank you very much.
Thank
Thank
you,
you,
everyone.
Amarjit.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir.